right, we're ready to get started with our next panelist. If everyone could take a seat. Okay, hopefully you had a nice break. We're going to start with our next presenter. This is Karen Peterson. She's a customer success manager with Craneware Group. Karen has supported the healthcare industry in the roles of finance, decision to support, supply chain, and pharmacy. She is a fellow with HFMA, holds a pharmacy assistant license in the state of Washington, and served as a budget officer for Washington State University. Her early career focus was on auditing. Help me welcome Karen Peterson.
Thank you. Let's see. Does this sound okay? Okay. I'm probably going to do some ad hocing here. On behalf of the Craneware Group, thank you for inviting us to present today. We filled a last-minute spot that vacated. And so I just want to add a little bit to my background because it sets the stage for the presentation and how I'm going to present some of the information. My early career was in auditing. I'm an accountant by trade. I've worked at Sacred Heart Medical Center, Central Washington Hospital before it was Confluence Health, Pullman Regional Hospital. So throughout my career, I've made my rounds through Washington State. This is the second time that I've worked with Craneware. I've been with them 6 years. And I ended up in pharmacy projects. And with a background in decision support, I went into the data. And my first group that I kind of ran really after was supply chain. And I love supply chain data, and this is what I used to present on. So when this speaking slot came up, I thought about what message I'd like to bring. And I thought about, you know what? I have spent the last 6 years with Craneware working on pharmacy and medication analytics. And I thought about when I worked in finance and decision support, there was so much that I wish I would have known. And I really didn't know that much about pharmacy. So today, what I wanted to bring to the team and to the group here was a presentation about medication analytics. And so I have some very detailed information. So we're going to kind of take a tour. I'm going to start very high level, and then I'm going to take us down a level. And then we're going to get into some examples of what you might want to look at. I hope that I have something for everybody here. And I've also, because I know we love takeaways, I have 3 takeaways at the end of the presentation that you'll have in the PowerPoint. One is a revenue cycle checklist that's specific to medications. One is a chart on what you might want to consider when you're looking at formulary files, and the other one is related to margins. So I've tried to accumulate much of what I've learned on this journey and bring some of it into the discussion today. So I hope that you like it. The other thing that we did, we received the request to speak about 2 weeks ago, and the Craneware Group is really great. They love to respond. And so this is the first time this presentation has been presented. This was designed especially for the Washington, Alaska chapter. It has not been presented before, and so I just kind of wanted to share that. And it's a little different than our pharmacy team might present. We have academic pharmacists and pharmacists on the team, but this is designed with the thought process around finance and how to take this journey. So with that, I'm going to go ahead and get started. So I might fumble a little bit here because I need glasses and I have a microphone, and I'm going to go through my slides and I have some notes, so bear with me. So let's see here. We'll go ahead and get these slides advanced, maybe. So I think I'm going to have to use the next slide, if that's okay. All right. So for those of you who are not familiar with the Craneware Group, we are a combination of companies that have come together. I know many of you may be Craneware customers. We're most historically probably known in the charge master realm. Next slide, please. We'll kind of pass along this because I have a lot of information to cover today. This is the information about best in class, and if we could go to the next slide. Thank you. So our learning objectives today are to discuss pharmacy expense and margins, understand some medication data sets, and also consider key optimization points for collaboration. Our takeaways are a medication revenue cycle checklist, key medication margin considerations, and common formulary file analysis points. Next slide, please. Now go ahead and follow along here. Okay, I'm doing this a little bit differently. I'm starting with some terms and definitions. And the reason that I'm doing that is, as we go through the presentation, maybe all of you aren't that familiar with pharmacy. And it's okay, because I wasn't either. And so there are some key terms that if you're not familiar with, you may want to be. And so I've included a few here as we go through. I'm not going to go through and read them all. They'll be in the presentation for you, so you have them as a resource. I'll give you just a minute to glance and kind of go through. NDC, primary NDC, HCPCS code, revenue code. You're probably familiar with those, but we're also going to talk a little bit about biosimilar drugs, generic drugs, and how to review some data based on therapeutic class. Okay, next slide, please. Oops, here we go. I'm trying to follow along. As well as 340B program, NTAP, which is New Technology Add-on Payments, and also P&T Committee. So some of these may be familiar to you, and some of them may not. Next, please. So as we get started, we're going to talk a little bit about the pharmaceutical landscape and where we are all at. I'm also going to ad hoc in a few things here based on some of the prior sessions that we've had. So I'm going to talk a little bit about denials, and I'll give you some hints of where to look for some things in the medication revenue cycle. So with our pharmaceutical landscape, we are dealing with increasing drug costs, supply issues, and drug shortages, complex data sets, high-cost drugs, and billing compliance. Nothing on this list is probably new to you. And I have it labeled as some components because in the business of pharmacy, this is just a handful of what we're all dealing with. Okay, next slide, please. So we're going to start really high level. So with our growth projections and outlook, I wanted to pull in a reference that talks about what is going on in the world today and where are we at with our pharmaceutical landscape. And I've included this study, which the link will be in the PowerPoint, for IQVIA, which is the Institute for Human Data Science, Global Use of Medicines. And this is a recently published study, January 2024, so it's always nice to have a newer reference. And basically what this is saying is that we are moving away with the declaration of the end of the COVID-19 health emergency. We are moving away from the communicative diseases, and the focus is going to move more toward chronic, which you might consider diabetes and cardiovascular. The reason that this is important is, again, we're starting high level, so what's happening in the world? So with the continued development of novel drugs, which to maybe put those in plain terms, novel drugs can be considered drugs that are being developed to treat the diseases in a different way. This fits into our missions because it can be life-changing. There are therapies being developed that are going to help treat patients that potentially had diseases that were untreatable 10 or 20 years ago. So it's a very good thing. In addition, we have the increased use of biosimilars and generics coming into play and becoming available. So I'm going to spend this a little bit more from our world in the hospital situation to where we look at where can we save costs and where are our high spend medications going. So we're going to have more generics and biosimilars available to use. From the drug companies' cost, the therapeutics and the non-biosimilars, they make more money off of those. But our focus today is really around innovation is good to help treat patients, but we need to be aware of when those biosimilars and generics become available. Okay, next slide, please. And I'm going to try not to lose everybody on this, end of the day on the second day of the conference. So let's talk about our current state. What are we dealing with in the hospitals? And so when we talk about for the pharmacy, our hospitals today are operating in a very challenging financial environment. Nothing new to the group here. The pandemic drove up costs, and we've had spending on specialty drugs. Meanwhile, pharmacy leaders are continuing to evaluate medication expense against what is best for the patients, payer coverage, and the hospital formulary. So I'm really going into the level of what is happening in the pharmacy departments and how can you work with them, and what is it that we should know to help support what's going on with the pharmacy teams. Okay, next slide, please. So now here comes the accountant out in me a little bit. So now we've talked about the higher level. Where are we with medication expense, and why should we care? So I'm going to talk a little bit about our pharmacy expense. We know generally where the pharmacy expense is in the financial statements, and I want to go through a little bit about why we need to drill down into the detail, some metrics, and talk a little bit about high-cost drugs. Next slide, please. So this is a common slide that you may have seen in some of the Craneware references. And it's talking about the cost of medications can be 20 to 40% of hospital budgets. Well, I looked at that and I said, gee, that seems a little high, because we're really, we like to talk about payroll and benefits and all of the other expenses. But if you think about this can vary by acuity level and which hospital you are. If you're Swedish, Cherry Hill, you're going to be higher. If you're a small rural hospital, your percentage is going to be a little lower. But the message to take from this slide is your medication expense and what you're spending on drugs matters. It is affecting your bottom line. And if you don't know where the money is, and if you're not following it, it's a really great opportunity to get to know this data set. Next slide, please. So when we look at our hospital pharmacy spend in detail, it's really important to drill down by department. If you think about at the financial statement level, where is the pharmacy expense? Well, except for some blood products, it's probably rolled into your supply expense. And I used to just really focus on the supply expense. I was really interested in the cost of implants and what was going on with materials management. Really didn't know that much about the pharmacy. It was kind of a, it was kind of a mystery to me. And so it's really important to know where your medication expenses are posting to your general ledger. What accounts are they in, and how are you following them? I'm also going to mention pharmacy purchase data. You may or may not know there are different kinds of accounts you can buy medications on. You can pay full list price, or you can purchase drugs under special discount programs, 340B. The procurement contracts are very important, and also another tip is to know where are your top 5 or top 10 medications that you're spending your drugs on. Are we on the right slide? Oh, I'm so sorry. Could you advance? Thank you. Appreciate that. I appreciate that, and our advancer's not working, so we appreciate the backup. All right, let's go ahead and move on to the next slide. The other thing I wanted to mention is metrics. We all love metrics, and so it's really important to consider this when you're looking at your medication expenses. Some common metrics used, and it matters whether it's inpatient, outpatient, or retail medications that you're tracking. You can look at per patient day, acuity adjusted, inventory turnover, and also contract compliance is very important. Patient population matters. It's a driver in pharmacy expense. And it's really important to do benchmarking. There's a lot of vendor software tools available, so I'm not here today to talk about the different vendor options that are available. One that I did bring in is our free one, our Washington State Department of Health. If you forget about this data source, it can be really good to go check out other year-end reports from other hospitals. So wanted to mention that. And then if you could go to the next slide, please. I brought in some common indicator recommendations, and this is from the American Society of Health System Pharmacists. These are some cost reduction indicators, and these are common metrics that are used. So something that I learned about metrics and decision support is there's a lot of different types of metrics you can use, and especially when you're trying to hone in on one or two subject matters. My recommendation is to pick a few that matter to you. And if you look at this list and you say, I have no idea, we don't track these, or this isn't in our data set, or our comparison, or our software, pick a couple and start to follow them. Or, of course, at this level, have your analysts follow them. Each data set is going to tell a story. See what your story is telling you, and you should be benchmarking against peers. So again, a lot of different decision support systems out there and vendor options available for benchmarking. But you should know where your medication expense is benchmarking for your hospital, for a like-kind hospital. Next slide, please. So next I'm going to get into a couple medication analysis examples. So we've started high with what's going on in the industry. We've talked a little bit about our pharmacy expense, and I've kind of put the question out there, do you know your expense well? Do you know what's happening with your medications? And if you don't, it's okay, you're not alone. I didn't know, and I didn't know that I should be knocking on the pharmacy door and making very good friends with the pharmacy director or others who may know these data sets. As we get a little farther into the presentation, I'll actually go through some of the data sets with you and give you some examples of how they relate to each other. So first, we're going to take a look at a couple simple ideas: top drug spend, reimbursement variance, payer margin, and 340B spend comparison. If you want to go to the next slide, please. Okay, thank you. You got the updated PowerPoint. I appreciate that. As I get into these, I'm going to talk about a couple concepts here. Payers pay differently. They do. Sounds like a very simple statement. It's important to know how your payers are going to pay. Contracts matter. And one of the main things that I see when I'm working with hospitals is that a simple contract matrix would be very helpful for your medications. And that contract matrix should be available to maybe just not finance or decision support, but there may be somebody in your pharmacy who could be very helpful in knowing what those terms are. And especially anyone who's reviewing your denials. They need to know what's in your contracts. I'll kind of put the question out there, do you know for each high cost or high volume medication what you're being reimbursed? And that's just a question to think about. If you don't, it would be a good data set to find out and maybe ask if someone has run an analysis. And then based on how your medications will be reimbursed, it's really important to review variances by payer and like-kind scenarios. Next slide, please. So again, I'm using some screenshots from an application that I use from Craneware, but this isn't about the application. This is about showing you some visuals. And it doesn't matter how you get there. You can use your Excel, your decision support, you can access your data sets through other vendors. But the important is to have a visual of what you might want to be looking at. So for example, this is drug spend example by therapeutic class. And what I've tried to do in this slide, I've actually typed in a few extra things. So when we talk about therapeutic class, it was a little hard to read at the bottom. So this is an example of sorting a data set and taking a look at the agents used to treat cancer are the top drug spend in this data set. I've added a trend statement that the angioplastic agents make up the majority of the sample data spent. So I'm kind of bringing my decision support background in here because any time you're looking at a graph or analysis or you're tracking your drug spend, make it easy for others to know what it is that you want them to see from the analysis. So it's always a really good idea to add a simple trend statement. So again, if you don't know where your money's going, this is one way to look at it. Start by therapeutic class and at least have the understanding of what categories your drug spend is happening in. Next slide, please. The next example is drug spend by NDC. And NDC is an important number to track. It is a medication level number. And it's really good to know, this falls along with therapeutic class, but where are you spending your drugs? So in this example, Keytruda, with the HCPCS code J9271, has the highest medication spend. So you may want to know which drug are you spending the most on. Now, this can tie into your contracting, as well as if you're having issue with denials. It's really important to know, where your money is going to. So again, just a simple example of something that you might want to run. Okay, next slide, please. Oh, and I think we might be a little out of order, but that's okay. Could you go to slide 19 for me, please? Okay, thank you. So this is an example of a medication margin level analysis. And why you may want to go down to a margin level, and again, this is thinking about how your drugs are reimbursed. So your inpatient drugs, you often think about reduction of cost. When you go into your outpatient realm, you have an opportunity to think of it more in terms of a margin level. So what are you being reimbursed on your outpatient drugs? So again, it matters, are you talking inpatient, outpatient, or retail? And I know that this may not be an area that you get a lot of data on. And so it's something, if this is a takeaway, to go back and say, do you know what? I really don't know how we're doing on drugs, what our margins are, where we're spending our money. It may be a good idea to go back and say, what analysis do we have available to us? And do we have any analysts in our facility tracking this type of information? You may have someone in your pharmacy, you may have a business manager who's tracking it. There might be information available. So again, just wanting to really kind of plant the idea, if you're not familiar with your pharmacy data, these are a few ideas to go back to your facility and think about. Think about what you have available. Okay, next slide, please. So you'll get a copy of the PowerPoint. It will be available. And I know that we're going through a lot of detail. So I did include in the next slide some analysis points if you want to go back and take a look at that screenshot. So we were looking at different biosimilar drugs by HCPCS code. All 5 of the drugs in the previous example had a positive margin in cash flow. So that is not a bad example to take a look at. But when you go in and start looking at it at a per HCPCS unit level, you will have an opportunity to see if you have an opportunity to further reduce your costs or an opportunity to further increase your margin. So I don't know. I know when I worked in decision support, I wasn't checking things at a HCPCS level for medication. So it's okay if this is something that you're not familiar with or you're not running current analysis on. Part of what I wanted to bring to you today was just some thought processes about some things you may be able to go back and take a look at. And again, it doesn't matter which system. You can use Excel, you can use your decision support systems. You may have things available to go into these data sets. And I'm going to take you on a tour of the data sets in just a moment. Okay, next slide, please. The last example I have for you in the analysis section is an NDC level example of a pure comparison group. So I included detail in these slides because I wanted you to be able to have information to come back and look at after the conference. You've been here, most of you have probably been here for a day and a half. I'm the last session of the day. Everybody's probably getting really tired. There's some really good detail in these slides. So you can have them to refer to. I've tried to add notes as to what you're looking at and why. And again, even though that these are screenshots from applications that I use at Craneware, that isn't the focus. The focus is really around, here is a visual, and you can go back to your decision support systems and other systems and pull some of this data and look at your comparisons. Thank you. Next slide, please. So let's talk a little bit about data sets next. So we've gone from the high level, what's going on in the medication drug spend area. We've talked a little bit about where is your medication expense in your financial statements, and a few thoughts about drilling down. We've gone through a couple medication examples, and hopefully I've provided some ideas that you may be interested in going back and exploring your data sets a little bit further. And now I'm coming down into the weeds. So after we go through some of this detail in the weeds, I will bring us back up to some higher level points. So I'm going to talk a little bit about the formulary file, purchase data, charge usage file, remittance data, claim data, charge master, and physician order entry. And when you think of medication expense, I don't know if you think of all those data sets come to mind that they're related. So the first question I will just kind of put to the group, does everybody know, or does anybody know what a formulary file is? Okay, I see Judy, yes, good. I didn't know. And maybe I heard of it, but I really wasn't sure. And I wasn't really sure why I would want to know about it when I worked in finance. So if we could go to the next slide, please. So when we think in terms of revenue cycle and charge masters, we all know, I think, what a charge master is. When we think in terms of materials management, I think we all know what an item master is. So when you think in terms of pharmacy, the formulary file is a very important record that can intertwine and derive some of your financial results. So it's really helpful to know in your organization who manages the formulary file and what data fields in your system interact with the formulary file to drive your financial results. And I'll give one example, is that oftentimes, and this can vary by system, so your terms in Epic are going to differ from your terms in Cerner and from Meditech, but a lot of times the cost lives for a medication in the formulary file. And when you have your markup policy applied, it affects what your charge is going to be. So if you have an outdated cost living in your formulary file, you have a very good potential that your gross charge is not going to be right. And so there should be mechanisms and systems in place to maintenance and control this formulary file, just as you maintenance your CDM or you would maintenance your item master. So the formulary file is an approved list of medications that are available for physicians to order and administer for patients. Most organizations have a closed formulary file, meaning that the medications need to go through a specific approval process, which is good. So why should we be familiar with this file? Well, to ensure the medications purchased and administered have the expense and charges captured correctly. It can affect your cost reporting, ensure costs are updated, and also, this is one of my favorites in a way, payers may require the administered NDC to be on the claim and the patient record. So think of this, the medication that's being administered to a patient down to the NDC drug level. Payers can require that that is the NDC that should be on the claim. Makes sense? You know, you want to track to the patient record. You want to bill for the right NDC. What happens when a system, and again, this can vary by what type of system you have, uses a primary NDC to default to? So I'm going to share a little bit in some of the terminology that I listed at the beginning of the presentation. A primary NDC, or in Epic, it's often called a red dot NDC, is one that is in when areas that do not barcode scan and they use a default NDC, when the scanning is not done by barcoding, the NDC that can get recorded can be the default NDC. What happens when that default NDC has not been updated? Well, an old NDC could be used. And so this can result in a medication based tracked at the NDC level. It's one coming off an old record. So recently, and I'm, of course, we'll just genericize this. I do work with hospitals all over the country. And so to genericize this, a couple comments about denials to tie into our earlier conversation. One scenario was a pharmacy had not been updating their formulary file, and the primary NDC had not been updated for a while. So an older NDC was going out on a claim. All of a sudden, denials started coming in, and the insurance company wanted proof of purchase of the medication. They wanted recent proof of purchase. Well, there was no recent proof of purchase. The purchasing was a while back because that NDC was not the one that was being purchased. And so this, of course, held up some claims that were worth quite a bit, and it was all being held up over this NDC. You can also have an issue with an inactive NDC, an NDC that's been inactivated, but is still live and available to use in the formulary file. Or you could simply have an invalid NDC. Somebody typed one in wrong, and it's going through. So when you ask, this sounds really detailed, why as a finance person do I want to know what an NDC is, National Drug Code? This is one reason. So when you're data mining or you're looking at denials, it might just be an important piece of information to kind of have in your toolbox to at least say, how is our formulary file? Is it healthy? Is everything current? Do we have ways that we're monitoring it? And is it affecting our denials? So that was just one example I wanted to share because I know we've had a lot of conversation about what's happening, with denial codes. Okay, great. Well, let's go on to our next slide. And I have another example I think I can bring in later. Okay, let's talk a little bit about purchase data. So our pharmacy purchase data, it's really important to know, and I'm sure your pharmacy knows, your buyers know. The pharmacy folks are really smart. So they know what they're purchasing on. So the message I wanted to bring today is if you're not aware of the different types of accounts that pharmacy can be purchased on. Here's a list. Now, AWP is not a type of account, it's a benchmark, but I included it in here more as a definition. So we have our WAC, or wholesale acquisition cost, and this represents the manufacturer's published or catalog list. We have our GPO, our group purchasing organizations, our direct purchases, or 340B programs. So for all of you that are involved in 340B, you know the management of your 340B is very important. In data sets, sometimes what can be identified as purchases happening on GPO, paying list price, when those purchases actually could have appropriately qualified to come in under the 340B program. So when you're looking for cost savings and efficiency, it's helpful to have an understanding of what kind of pharmacy purchasing accounts. And you should have a way to monitor. You need to know when something looks like it might be going out of an acceptable range. Next slide, please. So this is for all the revenue cycle folks in the room. I don't need to go through these files. You all know what they are, I think. But I wanted to list them in the sense of the information that is in your standard revenue cycle files for medications. It matters in the whole scheme of everything. So don't just think of the formulary file or the purchase data. It's important to understand in your systems how the data interacts. If you work in decision support and you like to data mine, don't forget about your claim data and don't forget about your purchase data when it comes to medications. So I've kind of listed these as data sets not to forget about if you want to take a look and drill down further. Next slide, please. This is just a very simple chart of typical data structures and some key fields. So I have just a quick example here: physician order entry, CDM, and formulary. So in this example, it is the charge code that is the link generally among these data sets. And this is an example of where the pricing on a drug would live in the formulary file. So again, Epic would look different, Cerner could look different, Meditech could look different. The names may vary, but depending on the system that you have, it's good to have a basic understanding of the fields. And you might think, okay, I have folks that do that. You know, I have staff that they're in charge of all this. And that is fantastic, and I'm sure that they do an excellent job. But sometimes, as leaders, it is our job to ask questions and ask the right questions. And sometimes in root cause analysis, we need to know a little bit about the terms, definitions, and detail to help them and to ask the right questions. So that's part of why I'm bringing such detailed information, you know, to this presentation today. Okay, next slide, please. Key collaboration points. So this is another really important part. How do we work together with the pharmacy teams? And again, my interaction with pharmacy at one point was I needed to, because we were short-staffed, I actually had to pick up a delivery of narcotics at the door and take it down to the pharmacy. I'm an accountant. That was like, okay, I can do that. So I they checked him in at the back door. I took the cart down. I rang the bell at the pharmacy, and they looked to see who it was. They opened it up. They took the narcotics. I signed for them, and they closed the door. And I thought, that's kind of scary. I have no idea what happens back there. And then I thought, you know, at some point, I should have an idea what's going on with this data set. But in my mind, that's what sticks as kind of real to me. It just all seemed a mystery. And the reason that we can collaborate, and when I work with different teams, so I primarily work with the pharmacy teams. And being an accountant and a decision support person, I will say, well, do you have anybody from decision support who might want to attend this meeting. And then you kind of sometimes, it's not uncommon for these groups not to work together. So if you work in revenue cycle and you're managing denials, or you work in finance or decision support, if you haven't recently met your pharmacy team or know if there's a business analyst, there's a lot of opportunity to collaborate. So how do we do that? Well, understanding processes is important, documenting workflow, knowing our key data sets and fields, building relationships, sharing information, and I think educate yourself. Maybe you know a lot about medications and pharmacies. Fantastic, good for you. I think you're way ahead of everyone else. If you don't, if there's a couple things that spark your interest in this presentation, then go ahead and learn a little bit more about them. And it will probably help your organization that you work for quite a bit, because every single department at the hospital, especially in clinical care, is using drugs. And so it interacts, and there's something to be found in each of the data sets. Trust me, I look at these data sets and I know. And so everybody has something to find and a story to tell or a story to find. Next slide, please. So we talked a little bit about the current state and how hard it is to manage your medication expense, and a lot of what the pharmacy teams are going through. So when we think about future state, it may be beneficial to view pharmacy as a revenue center. So it's kind of a shift in how you think. So viewing the pharmacy not just as a cost center, but as a revenue center, it's a much more comprehensive business line approach and sets the stage for collaboration. Expand our knowledge, can educate, provide data, be open to sharing knowledge, and embrace operational improvements. Understand the revenue side of the equation. Now, that wasn't the focus of this talk today, because as Judy and I know others can say, when it comes to medications, you could do several presentations from the revenue cycle side. But we had to mention it today because you can't talk about margins and you can't talk about reviewing medications without bringing in the thoughts around what's happening on the reimbursement side. But you have to be open to looking for what is going right and what may need to be corrected. Partner with the pharmacy leaders on technology, expertise, and resources to manage complex medication cycle from the procurement through the dispensing, charging, claims management, and reimbursement. Now, I don't know if any of you have ever experienced, when I worked in decision support, I worked with every department in the hospital. Some departments were very open to having finance come in and work with them and help them. Other departments, not always, not so much. And so if you don't have a relationship built with someone from the pharmacy team, it's a real opportunity. You're going to learn something, and you probably can help them. They probably have questions. So I work with one pharmacist who he does work with Craneware now, but he was a director of pharmacy. And I asked him, with this presentation, before you worked in a collaborative manner with your finance team, what is something that I could share with the group that you wish you would have known? And he said basically everything after the drug came in the door. He said, I wanted to know about denials. I wanted to know how billing units were being applied. I wanted to know how the claim edits worked. And I thought, well, that's so interesting, because I wouldn't necessarily have thought that. And he said, because I want everything to be recorded correctly and I want us to be reimbursed correctly. So it really opens the door to think about pharmacy as a partner or a future partner for you. Okay, next slide, please. This is kind of a nice list from, again, ASHP. And it talks about the different components that are generally handled by within the areas. So what are pharmacy-directed activities, and what are reimbursement and charging, and what are interdisciplinary. The reason that it's kind of a nice list is if you look at this and you go, yep, that's us, that's how we do it, you can see that there's points that you could get together and maybe expand that relationship. Okay, next slide, please. So I tried to bring some key intersection points for revenue integrity, finance, and pharmacy teams to work together. Payer contracts are often held with revenue integrity and finance, but pharmacy has a lot of information that can help when it comes to reviewing things. The P&T committee initiatives are much like a value analysis committee. It's really helpful to know what those initiatives are and how they tie into your overall strategic initiatives for your hospital. Policy and procedure development is an intersection point. Purchasing contracts are often held with pharmacy and the C-suite. But if you work in other areas, this may be a data set that would be helpful for you to have more information on. Charging policies, markups, and variances are a crossover point. Claim reimbursements and monitoring. Denial activity and account write-offs. And claim edit processes to ensure billing units and modifiers. So another example, when we talk about denials, pre-authorizations are really interesting. So when you're looking at your medication data sets, might be a really good idea to take a look at which medications, especially high-cost ones, are being denied because lack of pre-auth. And when you think in terms of lack of pre-auth, circle back to your contracts. What do your contracts say about pre-authorization for medications? Did you know a scenario that could happen? A pre-auth is obtained for a specific drug, medication, NDC. The clinician, pharmacist, goes to treat the patient, and that's not exactly the one they decide to use. So they go ahead and pull a similar one, use that. Claim denied. You know why? Because the pre-auth was received for the first NDC, not the one that was used. So what are your rules around the contracts? And what checks and balances do you have in your pre-authorization system when an order is made? How do you know that the pre-auth that was obtained for one medication is the one that was actually going to be used? So just a few thoughts, a few places to look, kind of how this all ties together. And again, denial activity, account write-offs, claim edit processes, and ensure the billing units and modifiers are correct. Okay, I'm actually doing pretty good on time. So I will have time to talk a little bit about these takeaways. So I've included 3 takeaways for you. So one is a medication revenue checklist. Then I have one on margins and one on formulary file analysis points. So let's go ahead and advance the slide and go to the first of the medication checklist. Now, Craneware does a lot of education, and so in one of their academy courses they have available, this checklist, I've refurbished it. This is very detailed, so I apologize at the end of the day to give you so much detailed information, but again, it might be something you could refer to or take back to your staff. This is a list. We have 3 pages here. These are some common points that you want to consider when it comes to your billing and reimbursement for medications. So I've done it in a quick checklist form here. All drugs, and this comes from some of Craneware's recommendations from their data team, regardless of route of administered or coverage, should be billed and reported on the claim. I've gone through, this list does go through what happens to set up a drug, things to think of, such as assigning the right revenue code, assigning the right billing multiplier, assigning the right billable units. So we can go ahead and go on to the next page. I don't want to lose y'all here right at the end. So this is really good information, though. So this checklist so far is all the things you should be considering. Your systems probably have checks and balances to catch this. If something isn't caught, these can be an area that definitely are worth following up on. And let's go ahead and go into the next slide, please. So I've also included here, so where can things go wrong? So in the medication revenue cycle, there are places where gaps can occur. So transposition errors, it sounds simple, but it can lead to, big problems. Incorrect mapping of a charge code in the order entry system, revenue codes not correctly set up, incorrect multipliers or incorrect billing units. Billing units are pretty important. This can cause over under payments. Incorrect HCPCS codes or alternate codes. A drug in the formulary, not the same drug as the one in the CDM. Primary NDC in the formulary, not updated. Medication cost in the formulary not maintained according to policy. And lack of pre-authorization or the medication is not approved on a payer contract. So again, if there's one or two things on this list that you think that you would want to go back and check with your team and make sure it's all covered, that would be fantastic. But this is it's meant to be a checklist, and you may have 95% of it covered, and maybe there's something on here that would be helpful. Okay, we've got 2 slides left, and I only stand between you and the last session of the day. So my next slide is for the business of pharmacy, the key medication margin considerations. So this is a supplement to thinking about medications from a margin sense. So I've listed for drug reimbursements, purchases margins, analysis points, some things to consider. And then I've also mentioned, around the trend statements, it's really important when you're doing analysis or bringing reports forward to be able to explain what you're bringing forward. And then also in payer negotiations, you can look at medication expense versus your reimbursement, and it can help you in your contract negotiations. Okay, next slide and last slide for today, for me. This is something I want to expand on a little bit more. This has to do with the formulary file, and these are some key analysis points. And I'll try and go through why some of these are important to review. So NDCs not in formulary, these are important because these are purchased NDCs that are not listed in your formulary file. Your pharmacy team probably has mechanisms set up to be able to catch these, because it's really important if something's being purchased and it isn't set up in your formulary file, there's a pretty good chance that it doesn't have a mechanism to be charged for downstream. So when new medications are being brought in, it's important that they're following the appropriate processes and being set up correctly, just as if you'd be maintaining a new charge in your CDM. So again, think of the formulary file kind of like a charge master in the sense of how it accumulates records, and it's important to keep up to date. You can look at volume analysis. So you can look at the differences between what you purchase and what you charge for those medications that would be chargeable. It can be an indicator of waste. It can be an indicator of mischarges. And it also might assist in your inventory level review. So it's a pretty simple concept. We're purchasing this amount of medications. I would expect to be seen, with markup, this amount of gross charges. And so for your high cost or high volume medications, that's a pretty quick analysis to run. If you see a gap in there, there could be some problems. Maybe you're purchasing one NDC, but you're charging out another. That can be a problem. Maybe you have an area that's not charging the medications. Maybe your Pyxis unit, maybe there's something wrong. Maybe the scanning's not happening. So if you see something falling outside of a threshold that you're comfortable with, this could be a quick way to identify any issues. Primary NDC. I talked a little bit about this earlier. Accurate default NDCs are important, especially in those areas that do not barcode scan. Also around, we talked about the NDC billing compliance. So it's good to have a basic understanding, and your pharmacy director and your pharmacy team will be able to tell you this. How do they maintain their primary NDCs? And how do they know when the update should be made? And do they feel confident that their primary NDCs are mostly updated and correct? And again, most important in areas that are not barcode scanning. Cost. So cost to benchmarks are important. So you want to make sure, that your costs, what you're paying for medications, are what would be expected according to your contracts. You also want to make sure that your formulary costs are updated. So one story was most systems have automated ways to update their formulary costs. And your pharmacy team knows about this, right? So it's good. There's automation happening. Sometimes automation can break. And so there was one instance where a cost update process had stopped running, the routine had stopped running, and it had gone undetected for a while. And so the formulary costs were not getting updated. In this particular system, guess where the charges were coming from? They were being generated off of the costs in the formulary file, times the markup. So the charges were falling behind. The gross charges were falling behind. It doesn't necessarily mean you're going to collect more. It could, depending on the medication and what payers you have and what your contracts, indicate. But when you're talking about the whole scheme of the accuracy of your finances, your adherences to pricing policies, your analysis and your historical information, it kind of matters. It's in there, right? You want your records to be updated. So it's just something to be aware of. How often are your costs updated? And then what does that mean to your pricing structures? The other area, and the last one we'll talk about today, is your HCPCS code. Some HCPCS codes, some systems build them in the formulary file. So again, I'm staying generic here because systems can differ and builds can differ. Their Epic builds can differ, Cerner, Meditech. So if your HCPCS code, if the source of it is built in your formulary file, then that is something that finance and revenue integrity want to be aware of, right? And we want to make sure that those codes are correct and right. Because if they're not, then that can cause denials and it can cause compliance issues. And so just be aware of which fields in your formulary file are built to maintain and who's watching those. And it can be a really great point for collaboration. So when it comes to coding, pharmacy needs our help. And so when it comes to coding or coding questions or what's the right HCPCS code, this is a great cross-functional conversation to have. And see if they, see what resources your pharmacy team may need. And it does matter. So I think the message as I wrap up today is, medication expenses are increasing. They do affect our bottom line. There are things we can do to monitor them. And it isn't historically an area I was aware of working in finance that we probably spent enough time on. You may have a fantastic analyst who knows a lot about this. And if you don't, maybe there's a few pieces here your team could work on. So the message today is there's great opportunity to cross-functionally work with your pharmacy team. If there's barriers to break down, go ahead and try it. Knock on the door, get to know your pharmacy team. They have a lot of information that's really going to help you. And as dollars are always tighter and we're always worrying about the margins, don't forget about your medications. So as we close today, thank you for letting us present today. I've been a long-term member of the chapter. This is the first time I presented in a long time, so I appreciate your patience. And thank you for hanging in there at the end of the day. Thank you.